Now we'll see an antibiotic that is not a beta-lactam, but still its mechanism of action is the same as beta-lactams, that is, it is a cell wall synthesis inhibitor. That is vancomycin. Its mechanism of action is cell wall inhibition, but slightly different. As we studied for beta-lactam antibiotics, they worked by inhibiting transpeptidation, but vancomycin will inhibit transglycosylation in the bacterial cell wall. Normally, what happens is that the N-acetyl glucosamine and N-acetylmuramic acid residues of the bacterial cell wall have terminal D-alanine residues. These D-alanine residues need to bind together to form the bacterial cell wall. This reaction is known as transglycosylation, and it is carried out by an enzyme known as transglycosylase. What vancomycin will do, it will bind to these D-alanine residues and prevent their binding with each other. And thus, transglycosylation will be inhibited. Once vancomycin inhibits transglycosylation, then you can imagine that transpeptidation will also be inhibited but indirectly, not directly via inhibiting the transpeptidase enzyme like penicillins and cephalosporins and carbapenems do. Vancomycin is the drug that you need to remember for methicillin-resistant Staph aureus and also for enterococci. It can also be used as a reserve drug for Clostridium difficile infection, but the drug of choice for C. diff is metronidazole. You need to remember this one. Now, despite its activity against Staph aureus and enterococci, these pathogens have also developed resistance to vancomycin. Vancomycin-resistant Staph aureus has also emerged, and so has vancomycin-resistant enterococcus. How enterococcus has developed resistance to vancomycin is basically by changing the terminal D-alanine amino acid with D-lactate. So this target is not recognized by vancomycin, and thus it is resistant to it. Vancomycin is only given IV or IM, and it is not absorbed orally from the GIT, but if you want to give it for the Clostridium difficile infection, then you can give it orally because it will not be absorbed and it will perform its function in the GIT where you intend to do it. The IV infusion should be slow, and if it is fast, it can cause a shock-like state called red man syndrome. It cannot cross the blood-brain barrier, and its elimination is via the kidney, so we need to adjust its dose in renal patients. The side effects, as I mentioned, is red man syndrome. It is actually a type 1 hypersensitivity reaction that is due to histamine release and thus leads to cutaneous vasodilation that causes flushing, fever, chills, tachycardia, and hypotension, and basically a shock-like state. It can also cause ototoxicity, and this ototoxicity is basically additive with other drugs and sometimes permanent. It can also cause additive nephrotoxicity with other drugs that are nephrotoxic. By itself, it doesn't cause that much.